Hello, and welcome to Module 4 of the DSM-4 to DSM-5 Crosswalk webinar. This course is designed to let you work at your own pace. The course includes 5 modules, each lasting approximately 30 minutes. At the end of each module is a post-test, which you will be asked to complete. Please note that if you exit a module before completion, there is no means to return where you exited. Please complete each module in a single setting to avoid having to repeat the information. All 5 modules need to be completed in order for course completion. In this module, the focus will be on the chapters and diagnoses that were first located either in the anxiety disorder section or the disorders usually first diagnosed in infancy, childhood, or adolescence. While many of the diagnoses that were previously in the anxiety disorder chapter in the DSM-4 remain unchanged, the chapter has undergone significant reorganization, with trauma and stressor-related disorders getting its own chapter, as well as OCD and related disorders being pulled out into a separate chapter as well. As you can see, selective mutism and separation anxiety disorder have both been moved into the anxiety disorder section. The criteria for selective mutism, specific phobia, and social anxiety disorder, which is the renamed social phobia, have not been significantly altered. However, the criteria for separation anxiety disorder has been changed to allow the diagnosis to be made in adults as well as in children, with the significant attachment figure being either a parent or a child. Aside from this change, the basic criteria remain the same. While the diagnostic criteria have not changed for the disorders of panic disorder, agoraphobia, and generalized anxiety disorders, there are a couple of things to note. The very first is that agoraphobia has been separated from panic disorder, as there is enough research to show that agoraphobia can occur without the presence of a panic disorder. Secondly, panic attacks can now be added as a specifier to any disorder rather than giving a secondary diagnosis of panic disorder. There is no separate code for the specifier, but it can be added to the narrative diagnosis. When we're looking at these disorders, particularly around attachment, it is important that we consider culture. We consider it at all times when we're diagnosing and providing treatment. But it is especially, I think, important here when we look at what is normal and how that varies from culture to culture when it comes to attachment. It is easy to identify anxiety in a situation where attachment norms vary, but it really may represent a cultural difference. For example, in many cultures, it's not appropriate to speak to someone of the opposite gender without a chaperone. It would be easy to diagnose with selective mutism or an attachment disorder, or however, it would be incorrect, as the person is, although they may be in genuine distress in this situation, it's due to a cultural factor, not due to an anxiety disorder. Similarly, attachment norms vary widely across cultures and may look on the surface to be characteristic of separation anxiety disorder or even dependent personality disorder rather than a culturally normative experience. The presentation of anxiety generally looks the same, fearful or irritable, but it is the cause that determines the diagnosis, and that may involve cultural factors unknown to the diagnostician, which is why it is important to always consider these factors. Obsessive compulsive and related disorders is a brand new chapter. The diagnoses were grouped together due to their similarity and for clinical utility. All of the diagnoses in this chapter present with some type of obsession defined as recurrent persistent thoughts or urges or images that are intrusive and unwanted, and or compulsions, defined as repetitive behaviors or mental acts that the individual feels driven to perform in response to an obsession or rules that must be applied rigidly. When we look at this, we can see each disorder centers around an obsessive thought or compulsive behavior. The obsessions occurring in body dysmorphic disorder center around perceived flaws or minimal flaws that significantly impact functioning due to recurring behaviors of seeking reassurance, comparing oneself to another, checking mirrors, excessive grooming, etc. Under this diagnosis, one subtype is noted, muscle dysmorphia, where the obsession is that one's musculature is not sufficient or that one's body is underdeveloped. Trichotillomania diagnostic criteria remain the same. However, the diagnosis was moved from impulse control disorders into the OCD chapter. This diagnosis, along with excoriation disorder, are included in the OCD chapter because they represent compulsive behaviors done to alleviate emotional distress or accompanied by anxious mood states. It needs to be noted that some excoriation behavior is related to substance use, particularly stimulants. In those cases, if the behavior is clinically significant, then the diagnosis of substance-induced obsessive-compulsive and related disorders would be given rather than excoriation disorder. The diagnostic criteria for obsessive-compulsive disorder remains unchanged as well. However, there are specifiers that allow diagnosticians to further elaborate on symptom presentation. So when we look at the specifiers, one of the main things that they focus on is insight. There is a significant variance among individuals regarding their level of insight, and the DSM-5 allows diagnosticians to specify this. Using the example of someone who experiences intrusive thoughts that their mother will die if they do not recite the alphabet 3 times every time someone says, "bless you." Someone with good insight will be able to state that they know this doesn't make sense and they know the compulsive behaviors do not actually keep their mother safe. Someone with poor insight would believe that their mother's safety likely was the result of their compulsive behaviors. Someone with absent insight would demonstrate a range from magical thinking to delusional belief that their mother's safety was absolutely the result of a compulsive behavior. This leaves the diagnostician with a dilemma if the individual has absent insight. While the DSM-5 does allow for someone who has a delusion related to OCD to not carry an additional diagnosis of delusional disorder, there may be times when the additional diagnosis would be given if treatment needs dictate or if the content of the delusion is outside of the scope of the obsessive-compulsive disorder. It also indicates 30% of individuals with obsessive-compulsive disorder will have a co-occurring tic disorder, which research has suggested may indicate a higher rate of genetic heritability. So there is a specifier as well for that. One of the new disorders added to the DSM is hoarding disorder. There were others that were considered when it comes to obsessive-compulsive behavior, but this is the one that has the most research. In the DSM-4, hoarding was primarily associated with the obsessive-compulsive personality disorder, with a notation indicating that severe hoarding should be diagnosed as obsessive-compulsive disorder. The DSM-5 identifies that there is sufficient evidence that this diagnosis has significant differences from obsessive-compulsive personality disorder and even OCD, resulting in an independent diagnosis. Hoarding can be diagnosed as obsessive-compulsive disorder If the hoarding is in response to obsessive thoughts of incompleteness, the hoard is an attempt to preserve life experiences or to avoid rituals such as endless washing or checking rituals. 75% of individuals with a hoarding disorder have a comorbid mood or anxiety disorders. Some surveys indicate greater prevalence in males, but females have higher rates of excessive acquisition. It was 3 times more prevalent in older adults than in adults. 80 to 90% of adults with this diagnosis will meet criteria for the specifier of excessive acquisition. And all of these can be notated in the narrative diagnosis. We're now going to move on to trauma and stressor-related disorders. The diagnoses in this chapter have been pulled together due to the similar etiology of the disorders. While each may have a different clinical presentation, all of them have trauma or exposure to stressor as a requirement for diagnosis. There is only one new disorder in the chapter. However, other diagnoses such as adjustment disorder and reactive attachment disorder have been moved into the new chapter from other diagnostic categories due to similarities in etiology. So one of the first things that we see is both of the is reactive attachment disorder and the new disorder, disinhibited social engagement disorder. Both of these have the same etiology. Both are the results of pathological neglect or abuse and present with disturbances in attachment. In essence, they are 2 sides of the same coin. Children with reactive attachment disorder are often unable to develop healthy attachments, evidenced by lack of connection with primary supports. Conversely, children with disinhibited social engagement disorder evidence unhealthy attachment patterns through indiscriminate attachment. So when we see kids with reactive attachment disorder, they basically don't attach to anyone. The flip side of that is disinhibited social engagement disorder, where they have indiscriminate attachment. Post-traumatic stress disorder, we're going to cover that a little bit more in depth in a moment. But one thing to mention is that they have made changes to who can be diagnosed to include those who are repeatedly exposed to adverse details of traumatic events, such as first responders or CPS workers. They do specifically state that the exposure cannot be through electronic media, movies, or pictures. There are additional changes that we will discuss next which apply to PTSD and acute stress disorder. The final note here is that adjustment disorder chapter has been folded into the trauma and stressor-related disorder chapter due to shared external etiology or trigger for symptom presentation. Other than some text revision, the actual diagnosis of adjustment disorders remain the same. When we look at post-traumatic stress disorder, there are a few changes representing some of the advances in research and understanding of the disorder. As the diagnosis of complex post-traumatic stress disorder did not make the final cut, the authors added the criteria of negative alterations in thinking or mood to acknowledge that individuals exposed to repeated traumas experience mood symptoms in addition to anxiety symptoms. Also, symptoms mentioned additional symptoms mentioned are the presence of pseudo-hallucinations, usually auditory, but flashbacks may be very vivid, including all the senses, and can be described as hallucinations. The difference being that it will all center around the trauma rather than other events. Additionally, paranoid ideation, difficulty regulating mood, these may all be part of the contributing factors to misdiagnosis, and so that is why the additional text was added to help people identify different ways that trauma response may be presenting. They also took out the need to have an immediate emotional reaction to event. And the reason for this is that for many people, particularly when we're looking at veterans or if we're looking at first responders, in that moment, they're kind of on autopilot. And so they may not feel fear at that time of the incident. It may not be till they get back home where there's some safety where they start to experience symptoms. So that criteria for an immediate emotional response was removed. It does have separate diagnostic criteria for those under the age of 6 to help clarify the difference in presentation. Basically, the symptoms are the same as the adult diagnosis, but there is a greater focus on behavioral changes and text revision to clarify how presenting symptoms will appear. There has been some talk about a complex post-traumatic stress disorder coming in one of the subsequent versions of the DSM. They really just couldn't settle on the criterion set and the name that they wanted to give to it. So that should be coming down the road within the next couple of revisions. Some things to remember: not everyone who experiences abuse, violence, or hardship will identify it as traumatic or will have PTSD. For example, I worked with some women who had grown up in environments where sexual assault was common, and they didn't, at the time, view their assault as traumatic. And so they did not experience typical PTSD symptoms or even any anxiety symptoms. Now, the abuse definitely had an impact on their life and that impacted their behavior, but it did not come out as what we would see as typical PTSD symptoms. I also worked with men who grew up in violent neighborhoods, and very few of them consciously identify the experiences they have had as traumatic. So while they may not meet criteria for PTSD, it is really important to note that many of these people have alterations in their thinking and behavior as a result of this exposure. But they may not meet full criteria. I like to get on my soapbox here for a moment. I have spent a significant amount of my practice working with individuals who have either had repeated exposure to trauma, and many of them were diagnosed either with mood disorder and or personality disorders. However, when their PTSD was addressed, they often no longer met criteria for other diagnoses. In our mental health system, most of the people we encounter have been exposed to traumatic events. And I really believe it's important to consider the impact of these events when assessing behavior and mood symptoms. There actually is some research to back me up on this. If you are interested in the effects of cumulative trauma, the Adverse Childhood Experiences study was a large-scale study done on this, and it's really kind of a definitive work on how childhood trauma affects not only psychological functioning and behaviors, but as well as physiological problems as well. Okay, I'm stepping off my soapbox now. Thanks for being patient with me. All right, so we are done with Section 4, and if you will please complete the post-test for Module 4, and then you may proceed to the final module. Thank you very much.